session summary will also be posted on our website after the meeting. I'm now happy to turn things over to the moderator for today's session, Amanda Humphrey.
Can you hear me? Great, thank you. Obviously a very hot topic based on the number of attendees of almost 600 people. We have a great list of presenters and panelists, and I know we all look forward to their insights in this very difficult time. Next slide, please. As we noted in the agenda previously distributed, Dr. Mike Lauer from NIH will be the plenary discussion. Dr. Lauer has been a good friend to FTP since his time at NIH and has joined us probably a half dozen or more times. He will provide some context on the COVID-19 pandemic and related science and some insight into NIH's work in this space. We then have a panel of experts from NIH, DoD, and NSF that will likely get into more of the operational aspects of what many in the audience, both programmatically and administratively, are dealing with. Next slide, please. As you can see from our list of speakers here today, as I mentioned, Dr. Lauer is the plenary speaker. We have Barbara Orlando, who is the DoD Grants Policy Manager, Michelle Bowles, who is the Director of Opera at NIH, and Dr. Stephen Meacham, who is the NSF Section Head for Integrative Activities. Some of you may have noted that Gene Feldman was previously on here, but Dr. Meacham was able to join us at the last minute due to a conflict that Gene had. And then lastly, I'm Jim Luther from Duke University, and also assisting with the moderating will be Alex Albanek from Johns Hopkins. Alex will be coordinating all of the Q&A, the questions that come in, so please feel free throughout today's presentation to send in some questions. Next slide, please. As you can see from the format from our panel today, or discussion today, is Dr. Lauer will speak for 25 minutes or so, and then we've set aside some specific time for Q&A. Again, feel free to send those questions in as soon as you'd like, and Alex will begin to kind of collect them and triage them. Then after that, the panelists will each present for about 12 to 15 minutes each, give or take a little bit. We'll have a little bit of moderated question and answer, again with Alex's assistance. Next slide, please. So as we decided how to focus these discussions, obviously what we wanted to understand were what were the most important things from a federal partner's perspective. What are the questions they're receiving, their program officers, administratively from a compliance standpoint. And then obviously we wanted to get input from the attendees here at FDP. And so we used a tool called Thought Exchange, and we sent that out to, we sent it out Monday a week or so ago. And at that time, there were about 300 individuals that had signed up for this session. And we asked them the question you see on your screen. What are the things that you're interested in hearing about? And our discussion is going to be focused on what our federal partners think are most important. And they'll certainly overlap with some of the things that are most critical from your standpoint. Understanding this is a highly changing environment, a highly volatile environment based on the swiftness of change and the type of issues that we're talking about. Next slide, please. So Thought Exchange is a tool that collected ideas, and you can see on the left-hand side, there were about 129, a little less than half of the 300 individuals at the time that contributed ideas, and they contributed 74 thoughts. So they went into this tool and they asked a question about programmatic reports or supplements. And over on the right-hand side is the type of institution. And you can see about 60% of the individuals responded from a public research perspective, 33% from private, 3% from federal, and 4% from other. As we look at the role of the institution, at least the respondents, 15 individuals were faculty, 87 were administrators, 12 were technical, and 6 were other. And then probably one of the most important questions that we asked was, what was the status of research operations on your campus? 3 individuals responded that it was fully shut down. 42 said it was almost shut down. 63 said partially shut down. 5 not impacted, and 6 other. So obviously a large percentage of the attendees here or respondents were affiliated with institutions where their on-campus research activities were significantly compromised. Next slide, please. So again, as I mentioned, 74 thoughts came out. 129 individuals, they identified 74 thoughts. Next slide. This word cloud is something that Thought Exchange created, and you can see on the bottom left in the yellow box, the word size drives the frequency that these words were mentioned, and the word color identifies that in any one thought, these ideas were grouped together. So as you'd expect, a lot of interest around the potential extension of OMB and sponsored deadlines at or around June 17th. Lots of discussion around the flexibilities and productivity and planning for the future and so forth. Next slide, please. So this is my last slide before I turn it over to Dr. Lauer. I'm going to hit these at a very high level, but these are the themes that came out of those 74 thoughts, roughly in sequential order, but frankly speaking, all of these items here were very highly rated. So every individual had the ability to go in, look at those 74 thoughts, and on a scale of 1 to 5 stars, annotate whether they thought it was really significant or not so significant. And these are the items that were identified. As I mentioned, the extension of flexibility. The next topic that was of great interest is non-productive time. Does it need to be tracked? What are the implications? How might it be used? Lots of discussion, I would imagine, from the faculty, but also administrative perspective about the potential loss of funds. What does it mean if my research was stalled and I have to restart elements of it? Concerns about audit, both the current audit year, whether that's the Single Audit Act, and how we are going to comply when the audit year ends in the next several months, as well as is there audit possibility in the future from IGs and others, and do we need to be aware of them? The next related to supplemental funding. I'm sure that'll come up for you, Dr. Lauer, as well as everybody on this panel. A lot of interest in that. Discussion about grant-by-grant reporting requirements. Recent discussion from NIH about the role of RPPRs, but there's other discussion about what communication should come from the faculty member and from the institution that is clarifying the status of the research, the status of finances and no-cost extensions and so forth. As always, the next two are everybody's favorite. Everybody loves consistency and harmonization across the agencies, and everybody is interested in managing burden. Specifically, a number of individuals brought up concerns about NSF's rollout of their current and pending and anticipated future rollout of NIH's other support, which I don't think is on the books yet, but we understand will be forthcoming at some point in the future. But a lot of concern about the distraction with COVID and what's going on there, and how do administrators and faculty deal with these other things. The last two things are concern about support for graduate students, PhD, and early career faculty. They're in some ways compromised population because of the nature of how they're funding. Some of them are in other states or other countries. They're critical to the research, and there's some concern about that. And then lastly, everything post-COVID, including restart and so forth. So those are the themes that came out from the input of the individuals that provided input through Thought Exchange. So again, thank you to our panelists. I'll now turn it over to Dr. Mike Lauer.
Okay, whoops. Did I do something wrong here? Just 1 second. Go. Okay, good afternoon. Jim, thank you very much. And I want to thank you and your colleagues at FDP for organizing this outstanding event today, and for giving us the opportunity to share our thoughts and perspectives. I don't have to tell you that we are currently facing a novel problem from a novel virus. This is called a novel virus because the human population has not seen it before, and therefore nobody has acquired immunity to it. This is a photograph of what the virus looks like. You'll notice it's round with these spikes. These are referred to as spike proteins, and the reason why it's called a coronavirus is because it has the appearance of a crown. Now, there's a lot of interest into how this virus came to be a problem in the human population. A number of years ago, a journalist by the name of David Kamen wrote a fascinating book called Spillover. This is about infectious diseases that spill over from animal populations to humans. And in fact, there are some authorities who believe that most infectious diseases are spillovers, that they either originate in animals or animals play a major role in their transmission from one person to another. So well-known examples of this would include SARS and MERS, malaria, influenza, AIDS now has been discovered to have been a spillover, and the coronavirus is an example of a spillover. Some people believe that the virus originates from bats, but it's not clear that they came directly from bats to humans. There are some infections that clearly have been transmitted from bats to humans, some that you may not have heard of, like Hendra and Nipah. There are some more better-known infections here in the United States, such as hantavirus, which came from mice. It's not totally clear how this virus came to come to humans. This is an article that appeared about a month and a half ago, suggesting that pangolins, which are a kind of anteater, these are animals that are traded on wildlife exchanges in China. And there was a thinking that maybe pangolins functioned as an intermediary host between bats and humans. It's not entirely clear that this is in fact true. But what is true is that this pandemic that we're currently facing is in some way linked to how human populations interact with the environment. All right, now I'm going to focus on what actually happens in people who are infected. This is an interesting graphic that comes from a recent article by Siddiqui and Mehra, and it illustrates the time course of the infection. So on the x-axis here is the time course, and the y-axis shows the severity of the illness. During the first week or two, the illness is characterized by a viral infection. And so there are typical viral symptoms, like a low-grade fever, a cough. There may be GI symptoms, a headache. Some interesting symptoms include loss of smell and loss of taste. And then for those people who go on to develop more severe disease, there is an inflammatory response where the body tries to get rid of the virus, but in the process of getting rid of the virus, it actually winds up causing a lot of damage to the body itself. And then this then leads to respiratory failure and failure of other organs as well. It's just biphasic pattern, and in fact, there are some people who have what really looks like a biphasic illness. They'll feel ill for a little while, maybe a week and a half, then they'll feel better. They think they're getting over it, and then all of a sudden things start getting much worse, and they wind up having to be hospitalized or worse. This biphasic illness is to a large degree driving the way we're thinking about a scientific research program. So here are some interesting features of COVID-19. One particularly interesting feature, which is perhaps the reason why we're having the meeting in the unusual way that we're having it today, is that this is a highly contagious pathogen. Now, to give you a sense of how contagious it is, there's a statistic that we use which is called the R0. This represents the average number of people who would be infected by an infected person. So the R0 is 2.5 to 3, which means the average infected person will infect 2.5 to 3 other people. If the average infected person will infect less than one person, we don't have an epidemic. Then the illness will go away. If that number is higher, then the illness will spread throughout the population. So to put this in perspective, the R0 for influenza is about 1.4. The R0 for measles, measles is perhaps the most contagious disease known to civilization, is 18. This is a high R0 of 2.5 to 3, and this is the reason why we're having this meeting remotely today. Okay, here are some other features. It's often asymptomatic. It's been estimated that 50% or even more of people who are infected either have no symptoms at all or have symptoms that are so mild that they would not seek medical attention. And yet, despite the fact they are asymptomatic, they're still capable of spreading the illness to others. There are some strange symptoms, such as loss of smell and loss of taste. And in fact, some patients have described this as being the first problem that they encounter. There's this phenomenon called the cytokine storm. So this is what I was talking about, the massive inflammation in which the body pours out chemicals and inflammatory cells that then leads to failure of the lungs and failure of multiple other organs, including the brain, the heart, and the kidneys. Another interesting phenomenon is what we refer to as hypercoagulability, meaning that the blood clots. We've seen blood clotting in arteries and in veins. This is highly unusual for a viral infection, and in fact, some of the current therapeutic trials are focusing on whether the use of anticoagulants may improve clinical outcomes. There are complications that involve organs other than the lungs, even the toes. There's a phenomenon which is referred to as chilblains or COVID toe, where the toes turn red and swell. And this is one of the phenomena of the disease. There is a disproportionate effect on underrepresented minorities, on the elderly, and on people with chronic disease, in particular hypertension, cardiovascular disease, and diabetes. And then more recently, there's been this rather scary Kawasaki-like illness in children. Kawasaki is a rare inflammatory illness in children of unknown cause, which can cause a variety of complications, including cardiac complications. And we're starting to see this now in hundreds of children. What exactly is going on here is at this point unclear. The illness has had a dramatic effect on population health. So this shows this is from the CDC, and on the x-axis it shows the weeks of the year. So 0 would be January the 1st, 52 would be December, and this shows the y-axis shows the proportion of deaths that are related to pneumonia, influenza, or COVID-19. Normally it's about 8 to 9% of deaths, and look what happened here in March and April. This increased to 25% of all deaths in April were due to pneumonia, influenza, or COVID-19. And this is absolutely unbelievable. And this is dramatically different than what we saw, for example, 2 years ago when we had a bad flu season when it went up to about 10% or 11%. There are various sources of data. It's amazing how much data there is on COVID-19. And for those of you who are data junkies, this can be kind of addicting. I will admit that I look at various COVID data websites many times a day. So here's one of them. This is from Johns Hopkins. This is a screenshot from yesterday. There were 5.5 million confirmed cases, close to 350,000 deaths. The United States is by far the country that has the most number of cases, something like 1.7 million cases. Now, these are some data that were taken from the Johns Hopkins site to look at the number of deaths per day. So on the x-axis, this is time. This begins at March the 9th. It goes out to May the 9th. And then the thickness of the colors represent the number of deaths per day. So it looked like the total number of deaths per day reached a peak sometime in mid to late April. And now across the globe, the number of deaths per day is gradually decreasing. The United States accounts for more than 1/3 of all the deaths. And of course, there are concerns that this improvement may not last. We may see recurrences or new outbreaks, perhaps because of relaxation of social distancing rules, or perhaps because we might see a second wave of infection. Those of you who are medical historians may remember that in late 1918, it was the second wave of the influenza pandemic. that led to most of the mortality as opposed to the first wave. Okay, now I'm going to focus on NIH. So there are a number of efforts at NIH to address what's going on with COVID-19. This is one is the launch of a private-public partnership. I'm going to talk about this in a bit. The Congress recently passed a bill for a program called RADx, R-A-D-X, or Rapid Diagnosis. And the idea of this is to develop platforms and technologies to enable testing to increase on a dramatically increased level compared to where we are right now. We would like to be able to increase the testing capability of the country to perhaps 10 times more than where it is now, and make it simple, cheap, point of care, user-friendly, and of course, accurate. We have published a number of funding opportunities, some of the funding is in the form of supplements, also supplements not only to grants, but also to our contracts. But there are also new award opportunities coming out, and would strongly advise you to keep track of the NIH guide and also our dedicated website where we are publishing these. I think one thing that's kind of amazing is how rapid the research has moved forward. So here's one example. This is based on existing clinical research infrastructure that NIAID has been supporting for many years, a trial of the antiviral agent remdesivir. Remdesivir was a drug that was initially developed for the treatment of Ebola. So a trial of remdesivir started in February, at a time when the epidemic was just starting here in the United States. The trial enrolled over 1,000 patients. It was completed in April, and the main results of the trial were published in the New England Journal last Friday. So this is, for a major trial like this to go from initiation to completion, this is an event that typically takes years. This all happened over a period of weeks. It's amazing. And then what's really cool is that the drug actually works. So what this shows here on the x-axis is the number of days after people are randomized. There were about 500 people randomized to placebo. 500 people were randomized to remdesivir. These were all hospitalized patients. And the y-axis shows the proportion who had recovered. Remdesivir led to a decrease in recovery time from 15 days to 11 days. There was also a tendency, a trend, towards decreased mortality. I think it was from 11% down to 7% or 11% down to 8%. So this drug actually works. It has real antiviral properties. The FDA has given it an emergency authorization use. So this is research going on at warp speed. That's a term that's being used. And I think it's incredible at how fast we've come from initiating a project to having a result that's actionable in clinical care. So now we have to go to the next question. So on the left here is a headline showing that the NIH clinical trial shows that remdesivir accelerates recovery. Well, what do we do next? So the next trial, we have a bunch of trials going, but here's one next trial, is a trial that's going to combine remdesivir, which is the antiviral agent, with another agent called baricitinib. Baricitinib is an anti-inflammatory drug. So remember I mentioned that there are two parts to this illness. There's the viral infection, and then there's the inflammatory component. So now what we're doing is we're combining those two aspects of the illness, the viral aspect and the inflammatory aspect, and we're going to see whether or not this kind of two-pronged approach will lead to even better outcomes. Okay, now I mentioned that another part of this is the development of a strong partnership between government and industry. Francis Collins has been the primary driver here. He has set up something called ACTIVE, Accelerated COVID-19 Therapeutic Interventions in Vaccines. This is an article that was published about a week or so ago in JAMA describing the nature of this. I believe that NIH and a variety of other government agencies now have combined forces with 18 pharmaceutical companies, and they are focusing on 4 specific areas. One of them is vaccines, the development of a vaccine. You may have heard that one vaccine candidate, which has been tested in an NIH-funded trial, appears to have positive effects. Now, it's not we can't say yet that we have an efficacious vaccine. But there will be large-scale vaccine trials that may be starting as early as July, which is a little over a month from now. A number of different vaccine candidates are going to be tested. They're also active is also working on therapeutics, clinical trials, as well as preclinical studies, which includes, for example, animal models that can be used to develop and test possible candidates. Now, if you think about what's happening in biomedical research, we're almost existing in a bipolar world. In the area of coronavirus and COVID, it's very exciting and things are moving at a very rapid pace. Everything else, it's kind of like what Jim showed you, the results of the poll that he took. We're seeing headlines like this. Medical research is locked down too. This is written by Kevin Sheff, who is a researcher at Yale. He's involved in NIH-funded stroke studies. And then this article out of STAT, which nicely articulates the anxieties that are being felt. COVID-19 has shut in scientific labs. It could put a generation of researchers at risk. Francis Collins, when he testified before the Senate Health, Education, Labor, and Pensions Committee, suggested that NIH could be losing $10 billion in lost research. That's an estimate that we made of lost productivity. Of course, we're hearing from many of you about this. And if you to put that in perspective, our total extramural budget, grants, contracts, and other transaction authority, about $35 billion a year. This may be an underestimate. This was a number that we came up with maybe about a month or so ago. The Congressional Research Service put out a report on April the 10th. The report was qualitative. I thought it was well written and certainly resonated with what we were hearing at the time, and it's still relevant today. And it described extensive disruption, which I'm sure you know about, laboratories being closed or nearly so. Communications are suboptimal. As amazing as Zoom is, and as amazing as it is that we're able to have this event that we're having right now, it's just not the same as seeing people in person. Conferences and meetings are canceled or disruptive, as we are witnessing here. Supply chains are interrupted and resources are lost. In particular, this would include animal colonies. We know that animal colonies, at the very least, there's no breeding going on, and we do know that there has been some culling, but then those animal colonies will need to be replenished. Widespread financial losses. We know about institutions that are losing millions of dollars a day, major academic medical centers losing $50 to $100 million a month. Required telework, and I'm teleworking, Michelle is teleworking, most of us at NIH are teleworking, has disparate effects, and it particularly has disparate effects on women and others who have child care and dependent care responsibilities. This is especially important with schools being closed. And I don't have to tell you this, anxiety is exceedingly high, especially for early career investigators. Now, NIH is open for business. Our staff are working remotely. We continue to process applications. By the way, the applications are coming in. We continue to make awards. We are conducting peer review meetings virtually. We have had essentially no interruption in peer review. And we will be continuing virtual peer review meetings for sure over the summer and possibly longer as well. And of course, we are putting on a number of funding opportunities. This is something that Michelle will talk about a bit more, and I know you have lots of questions about these various accommodations and flexibilities, which we have posted on our website, including some flexibility with application deadlines, donating research supplies, charging salaries and stipends to grants even though productivity is substantially reduced, issues related to human subjects research and clinical trials. Our Office of Laboratory Animal Welfare has been active. We've had a couple of webinars and extensive guidance to IACUCs. We are allowing extensions on reporting and flexibilities on expenditures, as well as accommodations for loss of time. I think these words largely express the or mirror the image that Jim showed a few minutes ago. As always, when there are questions, please contact us. Our grants management staff and our program staff are working, and of course our review staff are working, and so for specific questions, please contact us. If you go to our NIH grants page, grants.nih.gov, this will be the picture that will greet you, and it will take you directly to our website. Hopefully you've all seen this website. I would encourage you to look at the website often because we update it virtually every day. All right, what's the big question now? The big question now is, how do we reopen? We are very interested in how universities, academic medical centers, and other institutions are reopening their research facilities. These are websites that I've borrowed from a couple of places. One theme here is caution, safety, a phased approach. Of course, we're dealing with this at NIH. How do we reopen our own operations, our own research operations, as well as our extramural operations? And it's really another term that we use is return to the physical workspace. Some of you have been very kind and have sent me copies of your reopening plans. I would strongly encourage you, please, if you're willing to share this with us, please send to us. We are gathering, I don't know whether I want to call them best practices, but promising practices. It's very interesting to us to see how people are thinking about this. So please feel free to share directly with me, email to me. I've already seen a lot of these, I think this will help us all learn from each other. Now, one critical part of reopening is paying attention to what's happening in the neighborhood. Montgomery County, Maryland has put out this dashboard. I think they opened it up a week or two ago. It's really quite nice. It shows 7 high-level metrics, like the number of new cases, the number of hospitalizations, the number of ICU hospitalizations, the percentage of ventilators that are in use. You can look at this at a very high level. They give you colors to indicate whether things are going in the right direction or not. And then if you want to, you can click on any one of these and you can get detailed graphics. So this is for Montgomery County, Maryland. It shows that we still have a lot of hospitalizations, but the numbers are moving in the right direction. I know that there are similar kinds of dashboards that are being set up all around the country, but obviously a big issue for us, and I'm gathering that a big issue for you, is what's happening in the neighborhood, because certainly one thing is we don't want to contribute to worsening public health problems in the neighborhood, but we also want to know what kind of reserve there is. If our hospitals in the neighborhood are running out of ICU beds, then that has to give us pause as to how we're moving ahead with our reopening. So closing thoughts here, we're dealing with a novel virus with novel challenges. On the one hand, there's a lot of exciting science going on. There's some results coming in. We already have at least one treatment that works, and we have more exciting opportunities that are coming along. I talked to you a little bit about the public-private partnership, the effort to dramatically improve testing, supplementals, and more. On the other hand, for non-COVID research, which affects the vast majority of us, we're experiencing the opposite. We're experiencing extreme disruption and anxiety. We are very grateful to our colleagues at OMB for the accommodations and flexibilities that they have allowed us, and we have taken advantage of those and worked with you on those. Reopening is a work in progress. I think key themes would include a phased approach as well as careful monitoring. So thank you very much for the opportunity to be with you today. I would be happy to answer any questions. And, we look forward to hearing the panelists and also to a good discussion.
Thanks, Dr. Lara. That was great. As always, kind of informative and thought-provoking. So we appreciate you taking the time to put those slides together. Alex, do you have some questions that have come in? As Alex is looking at those, I'll ask a quick follow-up question. I think we all, well, I'll speak personally. We all watched with interest as Dr. Fauci very prominently displayed and talked about the great research over the last couple of months that NIH does and NIAID. It's great to see science in the news that way. Any comments on that?
So I have a couple of thoughts on that. One is that, yes, it is great to see science in the news this way. And so one thing I would encourage you is not only to follow this, but if you have an opportunity, you or a family member have an opportunity to participate in science by, for example, participating in a clinical trial or some kind of a population health study, please do. Now, we're seeing some interesting things, like NIH put out, NIH Intramural has a study where they're going to be measuring antibodies, and they're going to be using this to get a sense as to the spread of the infection throughout the country. They were planning to enroll 10,000 people. They put out a rather low-key announcement about this, and they received 400,000 volunteers. So that's great. And I was on this phone call where one of my colleagues said, I have good news and I have bad news. The good news is we have 400,000 volunteers. The bad news is that we have 400,000 volunteers. By the way, I'm one of them. I've long since given up any reality that I'm going to be part of this. So the Patient-Centered Outcomes Research Institute is funding a trial in healthcare workers. It's a trial of hydroxychloroquine, which of course is it's a drug that's been in the news a lot lately. It may be beneficial. It may not be beneficial. We honestly don't know. They are running a large-scale trial. In fact, Jim, it's being coordinated out of your institution, out of Duke. And the idea is to see whether or not hydroxychloroquine might prevent infection in people, in healthcare workers who are potentially exposed to people who are infected. Strongly encourage people to participate in that. So I would say, yes, this is one good thing that we are seeing is that people are being engaged in the scientific process. And I would strongly encourage any of us who have the opportunity to participate in some kind of research. This is a great opportunity to do it and to contribute to the effort.
Thank you. Alex? I'm going to keep asking.
Sorry, I was on mute.
Go ahead. Oh, go ahead.
Well,
Alex.
one of the
Thank you.
questions, one of the questions was about funding that I can't say it, hydrochloroquine. And so it sounds like, yes, you are. I think, why does somebody have to give me that word for the first one? But so it sounds like, yes, you are funding trials for such research.
There are quite a few trials that are going on. Now, I know there's been a lot of press. Initially, it's very interesting how the you might say the public mood swings. So initially, everybody was convinced that there's no question this drug works, and in fact, those of us who were involved with placebo-controlled trials were being asked, how can you possibly fund a placebo-controlled trial? Isn't it unethical to put people on placebo? Now the latest is that the drug may be harmful. And so now we're being asked the opposite question. You know, the honest answer is, and I've been involved with clinical trials now for decades in my own career, we don't know the answer. We have true equipoise here. There is reason to believe that this drug may have benefit for either preventing or treating this illness. There is also reason to believe that it may not. And the only way to answer this is through the conduct of trials. So I've seen some commentators say, really, the only appropriate use of this drug is within the context of a clinical trial. I personally would agree with that. And so I do hope that those trials will continue. As far as we know, we have not heard of any clinical trials that have been stopped prematurely by a DSMB, a Data Safety and Monitoring Board, because of a safety concern. So far, we are not hearing from clinical trials safety signals. But this is the reason why we do trials, is to see whether or not treatments either work, cause harm, or neither.
Okay, we have a couple more questions coming in. One has to do with, given the current situation, is there a reexamination of priorities of how the business public-private partnership is functioning when it comes to high public need but low possible profit issues for instance, antivirals, MDR, new antibiotics, rare disorders?
So this is a really interesting question, and I think part of the idea of setting up this public-private partnership was to de-risk research as much as possible. So, for example, they are working on common platforms and master protocols. So if you have a master protocol, it makes it easier for you to put your study together because you have a master protocol. You don't have to design a new protocol from scratch with every new study. Another idea, I don't know if this is going to actually happen, but another idea that's been bandied about are common control groups. So you could test multiple different agents without having to assemble a new control group every single time. You have one control group that effectively functions as the control for all agents. You have common endpoints. What that means is that it's possible to compare studies against each other, to combine data, and therefore leverage data against one another. So I think a particularly exciting part about the public-private partnership is exactly that, is to make it easier to get studies done more quickly and to de-risk studies for private entities that are interested in seeing their products potentially move forward. Great.
Another question regarding the chart that you showed about the remdesivir performance shows that the placebo is performing just slightly worse than the treatment. Could that be true?
Yeah, so if you look at this, it appears that the effect is relatively modest. The median time to recovery was reduced from 15 days to 11 days, and there was a tendency towards reduced mortality from, I think it was 11% down to 8%. So what does that mean? That means that this is not a cure. It is not one of these situations where if you get the drug, you live, and if you don't get the drug, you don't. But the effect is more modest. In fact, most of medicine looks like this. In most of medicine, the effects are relatively modest. I think one of the key points, and Dr. Fauci really said this very nicely, is it is a proof of concept. The question was, is there any way that we can attack this virus? Is it possible that we could use a drug that will have an effect against this virus? And what the trial says is, yes, we do have an agent that does something with the virus. Now, obviously, we want to do better than this. Ideally, we would like to get to a state where we would have a drug that would have a 100% cure. I don't think that's going to happen. That's something that almost never happens in medicine. But whoever asked that question, it's a very astute point. This is a modest benefit, but it's real. It does have real clinical meaning. This does mean that you like to use the drug if you can, but what it also means is that we have a lot more work to do.
One more question. For us non-scientists, can you explain the benefit of contact tracing over the next 1 to 2 years?
Sure. So contact tracing is one of the most basic tools that we use in public health. The idea is when we're dealing with, remember I mentioned that the average person who has this illness will infect 2 to 3 other people. The way we can prevent a person from infecting somebody else is to isolate them. The most extreme form of isolation is quarantine, where they literally are isolated from the rest of the world. But at the very least, you would tell them, don't come to work, don't be in a public place for a period of time until such time as you are likely to no longer be infectious. So the way contact tracing works is that we find a person who is infected. We do a test, and then we determine that they are infected with the virus. And then we start asking them questions like, where have you been the last few days? Who have you been with? What buildings have you been in? Are there people whom you have touched? And then we reach out to those people and we say, we have reason to believe that you may have been exposed to the virus. We would like to see you and test you to see whether or not you are in fact infected. Now, there are some countries that have done a really great job with this. And we've heard about Germany and South Korea. And in fact, South Korea, they've done some very interesting things. Like they look at cell phones and they look at what cell phones have been close to one another for prolonged periods of time. And that's a way in which you could potentially find a contact that you may not remember in your head. So it is thought that identifying your high levels of testing, identifying people who are infected, isolating those individuals until such time as they are no longer infectious, and then finding out who their contacts were and testing those people, isolating those individuals, may play a major role in controlling this pandemic. And in fact, there's some very interesting data coming from various parts of the world. One very interesting study that was reported out of the CDC that was based on a call-in center in Korea that suggests that this method can work quite well and can control an infectious outbreak.
Do we have time for more questions? Jim?
Yeah, we do. We have another 7 or 8 minutes. Yep, we do.
Okay, great. Okay, the next question is, the endpoint for vaccine research appears to be neutralizing antibodies. Is there a reason why the focus is not on T-cell immunity?
So now I'm going to have to admit, I'm a cardiologist, and immunology was never my strong point. I learned it at one point and then promptly forgot it. What I will say, because this is really something I know very little about, but what I will say is that multiple vaccine platforms are being tested. It is not clear which vaccine approach will work or which will work best, and that's why we're hearing about different approaches that are being used. One other approach, which is not vaccine but is also immune modulated, has to do with the use of convalescent plasma. So this is where we take plasma from people who have had the infection and recovered. Presumably they have developed antibodies that then can be used in other people. There have been some initial case series that have been encouraging. There are ongoing trials. And then another idea is to take those antibodies in plasma that seem to be particularly effective and amplifying those antibodies. So this is monoclonal antibody treatments. So for example, you may remember the first slide I showed you showed those spike proteins. The spike protein is thought to attach to a cell receptor that then leads to the virus entering into cells and then replicating. There are monoclonal antibodies that attack that spike protein, and so that's another area in which there's a great deal of interest right now.
Okay, so somebody asked, what are the lessons from the second wave of the Spanish influenza that can help us to avoid increased mortality when we have our second wave of COVID-19?
Okay, well, hopefully there will not be a second wave of COVID-19, or if there is a second wave of COVID-19, we hope that it is going to be less severe than now. Influenza and coronavirus have a number of common properties. One is that they are what we call RNA viruses. So the primary nucleic acid that leads to replication of the virus is RNA as opposed to DNA. Why is that important? RNA is a more unstable molecule, and therefore the virus can mutate more easily than a DNA virus like HIV. HIV is a DNA virus, which is more stable over time. So what we think happened in 1918, the initial outbreak was in the spring, was March, April. It was a severe outbreak, but it wasn't terrible. And then it ended rather quickly. Now, of course, 1918 was the last year of World War I. We had many young people who were being put into tight quarters, primarily the army camps, and of course the battlefields in Europe. So you had many people who were crowded together. This is like an absolutely perfect setup for a contagious disease. So the virus presumably mutated into a form that was more lethal, substantially more lethal, and then you combine that with you've got large numbers of soldiers in particular crowded into small areas. You have cities and science not knowing what to do and not even understanding what it was that they were actually dealing with. Was this a bacteria? Viruses at that point were not really understood. The influenza virus was not going to be discovered for another 10 years. And so it was an absolute perfect setup for disaster. And that is what happened, particularly in September and October of 1918, and particularly in cities that did not have a strong public health infrastructure, like my own hometown of Philadelphia, where it really went very badly. So I think, what are some of the lessons to be learned? Well, one lesson is that science is ultimately what's going to get us out of this. The state of scientific knowledge in 1918, as amazing as it was compared to 100 years later, was nothing like it is today. Today, we have a better sense of what we're dealing with. And so I think we have a higher likelihood to be ready for the second wave when and if it comes on. I think the other key lesson that we've learned is that public health infrastructure and public health interventions really do matter. Hopefully we're not going to have the kind of situation we had in 1918. Effectively, what we had was anti-public health. We had situations that that stimulated the spread of the virus as opposed to inhibiting it. By the way, I will admit that during the course of this pandemic, I have read a couple of books about the 1918 epidemic. My wife thought I was crazy. She said, you're not depressed enough. You need to get yourself more depressed by reading about viruses and plagues. But I will say there are some outstanding books that are out there, and they make for very interesting reading, particularly given what we're going through right now.
Okay, so Jim, I think we're out of time. We do have one more question, but as we said, we could either address this at the end during Q&A, or we'll be saving our questions and be sure that we get back to people.
Why don't you save that to the end, Alex? I do have one final question for you, Dr. Lauer. So, NIH has been so focused on early and mid-career investigators and supporting them with programs, as well as graduate students, postdocs, and so forth. I know the focus now obviously has been on the cure and vaccine and so forth, but has NIH been giving that thought as to how that population is supported in the future?
Yes, this is a top priority for us. As in years past, we are aiming to fund as many early stage investigators as we can. We are keeping track of where we are. At this point, we are funding at about the same rate as we were last year, and despite the disruptions. So our hope is that we will be able to fund a large number of early stage investigators. The other is that there are a number of early stage investigators who are asking for extensions of their eligibility time, and it's very easy. There's a website, you go and you ask. Essentially, all you have to do is say, COVID has been a disaster. We'll say we agree, and we can extend the time. We're also aware of anxieties around K99, K99 R00, and other K awards. And so at this time, and this is well articulated in our FAQs, we are allowing for time extensions. Yes, this is a major concern. It's a major concern for all of us, and it's something that we're going to be monitoring closely. We're doing as much as we possibly can, given the constraints that we are, of course, all living through.
Great, thank you. Okay, now we'll transition on to the federal panel. Again, I briefly introduced Barbara Orlando from DOD, Michelle Bowles from NIH, and Dr. Stephen Meacham from NSF, who's pinch hitting for Gene Feldman. Next slide, please. So I briefly threw this slide together, not to go into any detail, but Mike, Dr. Lauer began to articulate what NIH is going through. I would imagine that each of our panelists are going to begin to provide some insights as to what they've been going through since January, February, and March. And, this is kind of a university perspective. And I just highlighted a handful of things with certainly the focus on healthcare readiness and employee and student safety in March, right, when this all hit. But then again, a shout out, and I think you'd get a standing ovation to all three of the agencies and sponsors for your quick response in early March with the flexibility, right? It was I don't want to say unprecedented, because that doesn't sound grateful, because you always are quick to respond, but it was wonderful as we were trying to anticipate these types of things, how all the sponsors came out. But we were determining what to do with PPE and what to do with T-32s and how to contemplate shutdowns and summer effort. And then we're transitioning. Some of us are and some of us aren't, are beginning to talk about restarting and ramping back up, and what does that mean, and what does it mean to our cores, and what does it mean to our faculty, and so forth. And then in the future, it's going to be financial decisions, right? It's every institution that's listening in here is tens of millions, if not hundreds of millions of dollars of issues across all of their missions. And then down the road, we're looking at, as I mentioned before, potential for audit around these things. Whether that's a single audit that might happen in the next 3 or 4 months, or a longer term down the road. So I just provide this for a little bit of context, and you'll note at the top that I said it's 71 days, right? 71 days from March 17th, when much of this started. And I say at the bottom that this is draft and incomplete, right? There's lots of other things that many other universities have done, so it's not at all complete. And I think the important thing to understand is many universities are at different places right now. We at Duke are beginning the restart process and the planning. Others are ahead of us, others are behind. And again, that's a function of what's going on in the local environment. Next slide, please. So this is the themes that you saw in the earlier slide. I won't go through these. To the degree our panelists can address these, wonderful. But again, there'll be a number of these that, due to the uncertain status or the changing environment or the politics, that we can have a brief conversation about them, but not the details of it. So again, continue to send questions. Alex will review those questions, and we should have about 20 minutes at the end of this session to do Q&A with this group as well. So now I think I turn it over to Barbara.
Yes, thank you very much. And it's going to be very hard to follow Dr. Lauer's great presentation with a few of the mechanics that DOD is working on, and try to provide you some ideas about what we're doing at DOD, what we did, what we're doing now, and where we're looking in the future at different pieces with this. So I wanted to start very broadly within DOD, what was then going on. And I think it's important to reiterate every time we meet with groups, especially when we do a joint panel with other agencies, is to remember that all of our agencies have different missions. Not only do we have a different mission, we have different laws and regulations that govern how we do our operating procedures, how we make grant awards. Some of the agencies are able to have more flexibility than other agencies, just simply based on the laws that govern both the program as well as the infrastructure of that agency. We also have different leadership goals of how we're going to meet our missions, and they're going to be set, and those change over time. And as they change, so does our approach on how we handle our research, what kind of research we're going to fund, where we're going to put our limited federal resources, and where we're going to be able to put those to make the most impact to meet our mission, to do that. I think the other thing with DOD in particular is that we do put a lot of money into research efforts. It is a very small part of our overall budget within the agency. It's also done primarily through contracts. We have a large research contract portfolio that covers the whole gamut from basic through developmental research and moving forward with that. We have a much smaller portfolio within the department that goes around the research that's given out through the assistance award mechanisms and our other transaction authorities. So we keep that in mind. As part along with that, DoD is a very decentralized organization when it comes to making our grant awards. We are divided into basically 4 large components: the Army, Navy, Air Force, and the Office of the Secretary, or what's referred to as the Fourth Estate. We have those, they're pulled together, but even within them, we're very diversified in the types of awards that we make, the types of research that we conduct, and how we actually use the mechanisms. We were looking at, just an example, we looked at the readiness survey, and we discovered that we've probably got 25 different systems that are used to make our grant awards or to do some process of our grant award life cycle that are used depending on where we're at. So it's very diverse, and we do that in setting that up. We will continue. We've always worked with the other agencies to try to harmonize our research efforts, to make sure that research is moving, the enterprise is moving with that. We try to work as best we can within our laws, regulations, and mission to harmonize our processes with other agencies and to move forward with that. And we've always been on the outreach with the research community. I know that Dr. Griffin meets regularly with different organizations in order to gauge that research overall enterprise, where we're going, where we're headed, where do we need to strategically move ahead in doing that. So we're dealing all that. As we're talking, the then part of it is that we were looking at all these things. How do we move forward and do things? And as we were making changes, just as it did for you when we entered into this pandemic, we were stuck. Some of the things that we were moving forward with in centralizing some of our more processes and our grants moving forward that have been stalled or slowed down as we all have turned to address the various issues that have come up around the COVID-19 response and what we're working with there. We're having to change some of the scope of what we were doing in order to address the issues around COVID-19, all for good causes, but it has slowed down some of our things that we were trying to implement to move forward as an agency. Could we have the next slide, please? And I'm sorry, I am only on the phone, so I don't know when it's been changed, if it's gotten there. So what I wanted to do was put in this reference to the OMB memo of 2011. We got a lot of questions when that first came out of how we're going to apply it and how we're going to do that. Questions that came in from our grant, extramural grant community on this particular issues with this. This OMB memo that allowed for a lot of the flexibilities that we now have really only applied to research that and services that were necessary to carry out the emergency response related to COVID-19, not caused by COVID-19, but related to the actual COVID-19. So what we took a look at the time, and several of our agencies had available to do this, they looked at their scope of work. Could they work with the grantee organizations to change their scope of work? Were they going to be able to provide COVID-19 response? And quite honestly, what we found, much to our dilemma on this, was that we weren't able to change a lot of ours because of the authorizing legislation and the project itself. We weren't able to make changes to deal with that. So then later on, if you'll go to slide 3, please, as we did now, so in March 19th of this year, when the OMB memo M2017 came on, we were all very excited about that. we were going to be able to provide some flexibilities to our grant community that needed to be done to deal with this particular incidents that were occurring and all the things that were happening fast, furious, and quickly to move forward. We moved as quickly as we can, again, remembering that we have to bring in all these 4 units and all these different things into one harmonized discussion in order for us to say we as a department are moving ahead, not we as the Army, Navy, Air Force, and Fourth Estate are moving ahead at different paces, but how we were all going to move ahead, and that's what we did. And we were able to do this very quickly thanks to all the work and team effort of all these different agencies working together. So one of the pieces, so what we've implemented with this particular one is we've delayed the submission of your reports to go along with that. We've had non-fundable travel expenses that across the agency that, you know, if they were canceled, we're going to let you charge those to your active awards. We're giving no cost extensions when possible. The reason we're having to do that, and in some cases not able to grant the extension, is that the 5-year award was awarded all money from one fiscal year all up front, and that money will expire. You will no longer be able to use those funds. They will be swept away. And so we could extend it, but you're not going to be able to have any funds to carry that through. So that's why we're saying you need to look and work with your program office to figure that out if you're going to be able to do that. We did allow for the continuation of the salaries to be able to be charged to our currently active awards. It cannot be done to past awards. You can't go back and claim money on those. It was currently active at the time when this went into effect. And it is dependent on your policy for paying the salaries from, under these circumstances, from all funding sources. Now, we would like at the maximum extent possible that, you know, you're expected to institute reasonable mitigation actions and practices. If you're able to perform certain activities teleworking or working remotely, then you could, you know, perform those to do that. It's keeping up with those types of things you should be continued to do. And of course, we will, you know, charge those salaries to it. We did at one point have some confusion over this, and we hope that this early on got mitigated and everyone understood that we're following this guideline, and it is not necessarily on a case-by-case basis to do that, which does put us into some tracking. And one of the questions you had for tracking is you are expected to track all of the time that you're charging to this under the code that came in because of COVID-19 that was charged to your awards. Keep track of all that. That said, those are one things we know now. As IGs begin to do their review, as GAO begins to do its review of the COVID-19 things, we're probably going to ask you for some more information. I know that one time that we're looking at right now is just basically what is the financial impact you have for getting restarted. To do that, what other things have you lost in order to do that? Have you charged? How much travel did you have to get charged to this? What expenses were there that for things that had to be canceled that you continued with? Some of the other things that the department is doing that aren't necessarily tied directly to this particular type of thing, but we are trying to meet bi-weekly. ONR is meaning bi-weekly teleconferences with different associations from a university associations, societies, and that to discuss the COVID-19 impacts, not only the impact, but how do we move forward? What can we do? How can we help eliminate some of this? We've been looking into some new research projects that are directly related to COVID-19. Please remember, those are a lot of times contracts as well as grant opportunities in setting those up. we continue to work with our other agencies to do that, but we are engaging more with different organizations, COGR and various others, to try to outline what the overall impact across, not just the immediate impact, but the future of what's going to be happening with our research efforts to do that. Next slide, please. The next slide is really what I wanted to do is just provide you with where you could get some more information about with DOD and its response. And this is all on the basic research website, but you certainly can go into these and take a look. As I said, remembering that Army, Navy, Air Force are going to have a little bit, some different things. They're getting different funding. When we get funding, it goes straight to them. They can take care of that and set them up. So please go continue to watch that one. When it comes to the differences on changing your funding, I'm sorry. Let me get it right. Grants.gov, I wanted to address that a little bit because I know we've had numbers of questions around extension of due dates on those. You will need to continue to monitor the grants.gov due dates. A lot of our basic announcements are open. Our broad agency announcements are open for a large period of time. They have rolling dates on them, due dates. They have different time frames with them, and so some of those are changing and some of those haven't changed. Again, when we look at making a change to that date, we have to figure out how does that affect the overall structure of getting the research awards peer-reviewed, reviewed, and awarded all within the time frame that we have to do in order so that funds can be obligated correctly. And doing that, we have cutoffs of when we have to obligate money. And so we have to make sure we can do that. So a lot of those decisions are based on that particular one. And then we can go to the next slide, please. And this is the same slide that you all had brought up in a lot of things. I think that, you know, what is to come? This is what we're all doing. Where are we going to do? We've talked a little bit about time. Time is a big question. We've all got questions of how things are going to move, and we're trying to answer those questions. Time. When are we going to do this? What's the rolling start dates going to mean? Not just for us, but you as a university. Are you, my son's university is all going online. They're doing online their first semester back in the fall. They're not going to be having classes in traditional classroom settings. Will that then affect the laboratory situation? Will we have people being able to come into laboratories to work? Is that going to be extended? So those decisions are all part of what it is, and there's no one universal answer that goes across the board. Each one of us is individual. We're going to make those decisions based on what's best for our enterprise and our university. We're also talking about time. Again, someone brought up, and as Dr. Lauer was saying, we hope that it's not as impactful, but there is a question that's there, and we don't know of, will we have a second wave of this? And if we do, what impact will that have on doing everything that we've got? We don't know all these various timing issues that we have. Funding is a question. Are we going to have more funds? How are we going to use our funds? Are we going to be funding different types of research in moving that? We are very cognizant of our personnel questions. Are we going to be, we need to identify not just personnel that's being based on our mid-level researchers, our beginning researchers, but how's it going to affect our overall STEM in the future? Are we going to see fewer people wanting to come into the U.S. to work because of these conditions? Are we going to have different clampdowns on different things that are going to stop us from doing that? How's it going to affect the workforce within the government? A lot of people were going to retire and bring people in behind them Now we're not going to do that. And as funding becomes tighter, does that mean when we do retire that they may not fill that position, or they may do one person for every 2 people that retire in order to, with the money in doing that? But overall, I think what we're going to do is, in the long run, see changes in the way that our business practices are conducted. All over business, I think, is going to change in how we're looking at doing that and moving forward. And all of these questions are coming in. DOD is working with various agents to address those questions. How do we go about looking into them and moving forward with them? And so we're trying to take that, meet with you, and try to figure out how we move forward with there. Thank you.
Thank you, Barbara. That was perfect. That was great. Now we'll turn it over to Michelle Bowles from NIH to give her update.
Hello, everyone. Can you hear me?
Now we
Great.
can.
Very good. Thank you. Thank you for having me. As I'm coming behind Mike and Barb, I'm going to try to kick in and give you as much information as I can. First and foremost, I just want to let you guys know that you all remain near and dear to my heart. I hope that you all, as individuals as well as professionals, are doing well, and that your families are doing well, and you remain in my thoughts. Next slide. So where are we? As I was doing a thinking back to when we first began this, which seems like just one huge long day after Incura, when many of us were there at PRA and FRA, giving presentations in Puerto Rico and running back home as quickly as we can as the pandemic was escalating and ramping up. As we landed, the first thing that we wanted to do was look at what does NIH need to do to protect the research enterprise from the recipient community, both applicants, recipients, and as well as the NIH enterprise. And so in March 2020, OMB authorized agencies to utilize many of the flexibilities that you're taking advantage of now. I will say that NIH tried to get out, first and foremost, to get information, general FAQs out for you guys to make sure that you had what you needed in order to get started. We realized right away that there was going to be a huge impact on applications. There was going to be a huge impact on prior approvals. There was going to be a huge impact on pre-award, post-award, and closeout. So our goal initially was to get out general FAQs and to provide you all with just baseline foundational information that we could provide to you so that we could de-escalate those anxieties that we were all feeling. And we hope we did that in a manner that was expedient and helpful to our community. As you know, we've outlined the general FAQs. We also outlined the flexibility since then, and then updates as we continue. I just want to make you guys aware that on a weekly basis, we are trying to update our FAQs. We're trying to update our staff guidance, because one of the things that we know from the enterprise is that you deal with 24 different institutes and centers that have grant funding authorities. But for this, we want to make sure that many of our general questions and our specific questions are addressed in a very consistent and concise way. And so for us, within OER, and specifically within OER, the opera arm of OER, we really do try to put out our staff guidance, making sure that the FAQs map to the staff guidance, as well as putting out internal guidance so that our staff knows and understands what we are saying to the community, and that information is relayed in a similar manner across the NIH enterprise with respect to our recipients. Next slide. So where are we now? Right now, we're in a place where we know that our specifically M2017 flexibilities are nearing to expiration by June. Just a couple of weeks away, a week away, really. But what you should be encouraged by is that OMB is definitely engaging the federal partners and allowing us to participate in those discussions and working with OMB to consider whether these flexibilities need to be extended. And I will tell you now that the OMB has heard from the NIH leadership. That would be Dr. Lauer and, of course, Dr. Tabak. Understanding and knowing that with beyond a shadow of a doubt, NIH supports continuing all of these flexibilities. And so we are definitely partnering and working together with our federal partners in the research platform to make sure that folks understand our voices need to be heard, and we want to make sure that we are connected to you all in a way that represents your needs. We continue, like I said, to review our internal and external guidance, and we want to make sure that we address our high-level policies, but we've received hundreds, if not almost thousands, of questions from the recipient community asking various questions, some similar, many in different ways, and we understand that different activities, different requirements, different authorities, different administrative requirements may require for you guys to ask us different questions, and we encourage that. We really do. My team and I, and along with others across the NIH, we are looking at the questions, we're poring over them, we're trying to make sure that we address them very clear and concise, as well as aligning them with the flexibilities, because we understand and know that at some point there's going to be that audit piece that you all were talking about earlier, that we want to make sure we cover you. Our goal in responding and as detailed as we can, and maybe perhaps not being able to extend some flexibilities in that way, is that we want to make sure that whatever we give you, it stands the test of an audit. Because when all of COVID is over, we need to make sure that you guys are not at risk, and nor are we. And we partner together in making sure that those risks are identified both within our requirements, aligning with the OMB requirements, as well as highlighting deviations within the enterprise that we need to offer to our institutes and centers to make sure you have what you need. We consistently, like I said, on a weekly basis, just pour over those questions and making sure that we are addressing them. Not only do we address them for the external community, but we also address them for the internal community as well, right? Because within the NIH enterprise, there are so many different questions that come through where we are actually deviating from our standard requirements. We want to make sure that our grants management specialists, our program officials, and others understand what those needs are. We work very, very closely with our peer review officer, our program officers, and we want to make sure that everything that we say externally is identified and replicated internally, so that whenever you submit questions to us, we want to make sure that those responses are clear, concise, and meet the requirements. So again, that's that documentation audit trail that we want to provide for you, both internally and externally. Next slide, please. So what's now? A large part of what we have heard as we're working with our partners, both FCP, COGR, ARI, and others, we're hearing a lot of questions about, okay, what does this mean? What do you mean when you say that, you know, you can charge salaries, and how do we charge these salaries for the initial support? Or do we want to make sure that that the documentation and reporting these delays, do we just send a single memo to NIH to say, oh, NIH, we've been impacted as an institution, and is that sufficient? So what we've tried to do is we've tried to update the questions and make sure that we update summer questions regarding summer appointments, for instance. Making sure that we update questions regarding your emergency and disruptive event policies at your institution. Making sure that we continue to talk about paying for ongoing work, whether it's telework or in the lab. So we really are trying to hear what those questions are, think about it now that we are well into COVID, and trying to make sure that those questions that we addressed initially at first blush are now fleshed out and give you what you need so that at any rate, you can have the documentation and provide us what we need in order to protect us in the event that we're audited. For the documentation and FAQs that we have, one of the things that we've tried to be very clear about is initially we directed folks contact, your funding IC, but we didn't provide details on that. So now we've updated it to provide details on that. Recipients have been unsure as to how to proceed on those draft letters. We've provided additional details on that as well. And then based on the feedback that we consistently give, we really do just try to take the time to update and perfect the FAQ in a way that protects you against risk as well as ourselves. Next slide, please. So what's to come from NIH? Many things, but the main thing you need to understand is that you have the NIH Enterprise Support. We will continue to support our recipients in ways that we have not had to do in the past, and this is very precedent. So one of the things that we want to be sure of is that we stay connected both to HHS and OMB and understanding and promoting the need for extending these flexibilities for our recipients. That's very critical and very important to us. Another one is that we want to continue to consistently apply those flexibilities across the research platform and being consistent with and partnering with our federal agencies where we can. I think Barb raised a really good point in that we have some limitations in that, there are different missions, different granting authorities, and different statutes and legislative requirements that govern us. But at the end of the day, we're all suffering from the same issue, and that is COVID has hit us, and we need to, as much as we can, identify those similarities where we can and apply those flexibilities in a consistent manner, and that is something that NIH has promoted to OMB. The other one is that we will continue to update our FAQs. As I said, we consistently receive them, we review them, we consider them, and so we don't want you guys to think that we're not looking. We are looking, and like I said, we receive many, and what we try to do is put them in buckets that make sense to us and to you as it relates to those administrative requirements, and we consistently will look at ways to help you understand how to restart your activities. Because this is new to us, we want to make sure that any information we provide to our recipients, it's information that you can use and that will stand the test of an audit and that you can document to us and to yourself and for yourself. The last thing that I want to really let you guys know is that we are implementing an NIH internal control plan and a risk management plan for HHS regarding COVID supplemental funding. And that is something that I think Jim Luther talked about initially, talking about the audits and talking about the need to make sure that we have documentation and that you all provide us the correct documentation. So next slide, please. That is the NIH internal control plan, I think is really important for us to share with you guys kind of what we're going to be looking at from our approach. And initially, I think you all know that from a pre-award standpoint, everything that we require is outlined in our FOAs. Our funding opportunity announcements outline the requirements for the use of those funding. And what we do is not only outline for you what we need and outline for ourselves what we expect and what those administrative requirements are, we're also submitting a forecast report to the Department of Health and Human Services on upcoming funding opportunities, so they know what we're planning to fund, and so that we have a transparent theme across the department, within NIH, and with our recipient and applicant communities. As you well know, all of the terms and conditions are outlined in your Notice of Grant Award. As you know, that is your legal binding document, and it will outline and restrict all of the authorities as it pertains to the use of the COVID-19 emergency funding. We have identified ways to track these funding so that, as you all know, USA Spending is the federal-wide data transparency method for outlining for our taxpayers what funding is spent, when and where for each agency. That's a federal-wide requirement. We're funding and tracking those COVID-19 funds with document numbers, as well as we're using separate type 3 or activity code grant numbers in order to have an internal way of us tracking it, so that if we're asked, even under an audit, or if you need information, you can track it the same way. And that is very important, because as auditors come in for your institution, you need to be able to tell them that you all have a tracking mechanism that NIH has offered, which is the document number and the type code that is attached to your supplemental funding when it's supplemental. We have received 3 buckets of COVID supplemental funding, and we are identifying them as such. And so I think for us, one of the things that I just want to make sure of is that our NIH internal control plan is the goal here is to share with you what we're looking at, why we're looking at it, and the approach that we're taking, so that you can manage and track and document your funding the same way. And that protects both of us. Next slide, please. As you well know, many of you have my personal email, my NIH email, and my cell phone number. If you have questions, you need to call. I do encourage you, though, to use the grants policy inbox to contact us for standard questions for your applicant or recipient organization. We are very, very committed to managing and tracking that grants policy inbox. If you don't receive a response within 24 hours to 48 hours, I encourage you to then reach out again and copy myself so that we can manage it and make sure that you're getting the answers that you need. Of course, I do encourage you to follow our OER website that will allow you to see all of the documentation, all of the information that we're sharing with you regarding COVID-19, and making sure that you consistently are managing and reviewing and staying up to date on that website. We are committed weekly to updating our questions, and we do, and my team, we take the time to do that. So we really do encourage that you use that as a resource for yourself so that we can get you what you need. And of course, if there's a question that is not being answered or that doesn't meet your needs, of course, you should reach out again. So with that, I will stop and turn it back over to Jim, and I thank you for your time.
Thank you, Michelle. Thank you. Now I'd like to introduce Dr. Stephen Meacham, who is joining us from NSF.
Thank you. I appreciate that, Jim. I guess my first question is, can people hear me? Yeah, okay.
Yes, we can. Perfect. Thank you.
So I'd like, first of all, to thank you for the opportunity to meet with you today. I really appreciate the chance to benefit from your expertise. I'm particularly interested in learning about the challenges that COVID-19 pandemic has created for research projects and for the faculty, students, postdocs, and other research personnel involved with these. NSF is eager to find out what challenges the researchers and institutions that it funds anticipate in the months ahead, and also any suggestions you might have about steps we might take to mitigate those. Next slide, please. So I'm sorry to say I'm not Jean Fellman. Jean, who was scheduled to take part today, regrets that she can't be with you. She was very much looking forward to speaking with you. Unlike Jean, I'm not with NSF's Policy Office. I'm from the Office of Integrative Activities, and one of my roles is to co-chair the NSF Recovery Planning Task Force, along with Sylvia James, the Deputy Assistant Director of the Education and Human Resources Directorate. Next slide, please. So I'm going to talk a little bit about NSF's response to COVID-19, both about some research funding opportunities and our approach to planning for the recovery. Next slide, please. With research programs at almost 2,000 academic institutions across the country, NSF is well positioned to mobilize the full force of the scientific community to understand and combat SARS coronavirus 2. NSF has a rich portfolio of research that serves as a foundation to help us understand questions about the ecology, the evolution, and the mitigation of viruses. And this has allowed the research community to respond quickly to this particular outbreak. As this slide illustrates, there are numerous funding programs across NSF directorates that support research into infectious disease systems and the translation of that knowledge into policies and applications to protect society. Over the last 10 years, these programs have funded research on topics like those we're seeing in the COVID-19 related proposals and awards. And this research provides a springboard for success in the work that we're now funding on COVID-19. One example program in biological sciences is the ecology and evolution of infectious diseases. That seeks to advance understanding of the dynamics of pathogen transmission within and across species and environments, including humans, non-human animals, and plants, and is in partnership with other federal agencies. Next slide, please. NSF has issued several Dear Colleague letters related to a rapid research response to COVID-19. The first listed here encouraged inquiries about the submission of rapid research proposals. Rapid is, and when it's in uppercase, is a mechanism that NSF has to turn around short research proposals very quickly. We received thousands of inquiries and hundreds of proposals. As of this morning, we have funded approximately 500 COVID-19 related rapids and eager proposals. Eager is exploratory grants for experimental research, as well as roughly 50 other COVID-19 related proposals. So someone, I think in one of the questions had asked, is NSF spending any of the, our agency spending any of the COVID-19 supplemental appropriation? The majority of the 500 COVID-19 rapids and eager awards that we have made are funded with that special appropriation. Not all of them, but the majority of them. So we're well on our way to exhausting that appropriation. As you recall, NSF has provided 75 million under that supplemental appropriation and an additional 1 million to help support the cost of administering those activities. And we, I think, have spent at least 57 million of that 75. We also have a lot more of these proposed COVID-19 related rapid proposals moving through our internal processing pipeline. So we're expecting the full 75 billion to be exhausted very quickly. Next slide, please. Most of the rapid proposals break down into 6 very high level themes. Those are the ones in the blue boxes on the right. I mentioned that we were also funding some eager proposals. The majority of the proposals that we've funded with COVID-19 funds are rapids, but we have funded about 16 eager awards. And all of those also fall within these 6 themes that we see in the COVID-19 rapids. The other thing to take away from this diagram is how all of these themes touch on, or collectively touch on, all of NSF's research portfolio. All of the directorates involved in funding COVID-19 related rapids. And the themes are pretty much what you would expect. The fundamental biology of the virus, predicting the spread, novel ways to detect the virus, approaches to limiting the spread of the virus, and especially the impact of behavior and the impact of the pandemic on society in the longer term. Next slide, please. So as you're aware, the COVID-19 pandemic's had a major impact on all aspects of the science and engineering enterprise. It's really been a major disruption of science and education research, as well as STEM education at all levels, from K-12 through early career faculty. Some of the far-reaching ways in which the impacts of the pandemic challenge the research enterprise are depicted on this slide. Researchers, both faculty and students, have had to abruptly halt their work, sometimes resulting in the loss of data, samples, even years of work in some cases. Some major facilities have had to curtail operations, and in doing so, shut down equipment that is costly to restart. Financial pressures on academic institutions may create a number of stresses for the research enterprise. Early career job opportunities may be reduced. Institutions may lose the significant gains made in broadening participation, as reduced support for undergraduate and graduate research may disproportionately impact more vulnerable groups of students who often depend on work study and part-time employment for financial support. Without steps to mitigate these impacts across the research enterprise, some institutions may even struggle to stay afloat. Finally, US science thrives on international collaboration and the foreign students and postdocs that come to work here. However, we may find that in addition to just the challenge of having foreign students and postdocs or even faculty members who are currently abroad returning to the US to restart their research, we may find that foreign partners postpone or de-emphasize their international collaborations as countries and communities focus on their own immediate needs. While NSF has also faced challenges, we're fortunate that our merit review process is holding up remarkably well. We're still receiving proposals, reviewing them, and making awards. Our transition to 100% virtual panels has made it easier for some people to participate in the review process. And we're fortunate that this time of year traditionally coincides with a lull in proposal submissions as academic researchers wind up their academic year. We're monitoring submission rates to check that they continue to follow that usual seasonal cycle, and they seem to be doing so. Next slide, please. So NSF, rapidly recognizing that it would need to do some long-term planning, stood up a recovery planning task force, and it's charged with helping the agency develop a strategy and timeline for facilitating a smooth recovery of normal research and education activity by NSF grantees, and identifying what additional resources might be needed to achieve this. We're taking an approach that relies very much on reaching out to the research community for their help in identifying what the medium-term and long-term issues are. We've been reading various articles that have appeared in the scientific press. We've seen some of the letters that academic institutions and their partner organizations have been sending to Congress. And what we're trying to do is compile a scalable plan for mitigation activities that have the flexibility to respond to different resource scenarios. One of the things that we've quickly recognized is that the damage to the research enterprise is so significant that really to remedy that requires significant resources beyond those that we currently have. I think we are drawing conclusions very similar to the ones that Mike Lauer talked about for NIH, namely that to repair some of the damage that's been done to the research enterprise is going to require resources that are, in NIH cases, I think they identified something on the order of a third of their overall appropriation, and we're seeing something similar from our first initial estimates. But what we would like is help from the research community and helping us refine those estimates. Next slide, please. So rather than going into an in-depth discussion of the issues and challenges, many of which you are all very familiar with, I'd like to give you a very high-level view of how we're organizing them and provide some examples of that on a later slide. One set of challenges is what we're calling research recovery. It's associated with recovering the projects and facilities in which we're already invested. A second set is associated with maintaining the STEM talent pipeline. This is having, as some of you have already noted in your questions, a significant impact on opportunities for graduate students and postdocs and early career faculty. And we really want to avoid the potential loss of STEM talent that, if it occurs, could set back US research for several years to come. Both of these challenges involve impacts on people and, in fact, on infrastructure. And so to remedy them, they're going to require investments in people and investments in infrastructure. If additional resources are available to actually meet these needs, then we'll also need some to make sure that NSF itself has the capacity to implement some of these recovery measures. Next slide, please. So NSF has, as a number of other federal agencies have done, has posted a web page with guidance to the community, and that includes lots of links both to federal information on coronavirus and also additional pages of guidance that are specific to NSF. I'm not going to go through some of these in detail because they're very similar to things that you've already heard about from NIH and DoD. If we could go to the next slide, please. As I mentioned, you've already heard a little bit about the way in which OMB has provided additional flexibilities, and NSF has come out with implementation guidance around those flexibilities. Next slide, please. We have also provided some guidance on the human subjects research and research that involves vertebrate animals. And this has been similar, I think, to the guidance that NIH has provided. We typically require that all projects requiring human subjects and animals must have either an approval or a determination of exemption from an IRB or IACUC before issuance of an NSF award. Given the current pandemic, many of those bodies have suspended their activities or have greatly reduced capacity. So NSF will accept a review pending determination notice in place of an approval or exemption determination. That would allow the PI to conduct preliminary or conceptual work that does not involve human subjects or animals, while a protocol is being developed or under review, consistent with institutional guidelines. There's also been posted some guidance for major facilities and contracts. This is really intended for entities that manage some of the NSF major facilities under corporate agreements or contracts. There are also a whole host of frequency answers questions aimed at PIs, sponsored research officers, people in receipt of SBIR and STTR awards, as well as some additional information for REU sites and so forth. We've been operating in 100% virtual panel mode now for a couple of months, and that's been going extremely well. There are some FAQs for NSF panels posted on the website as well. Could we go to the next slide, please? So I'm not going to go into detail into the OMB flexibilities. If you have questions about these, I would encourage you to send them to policy@nsf.gov. Next slide, please. Just a little bit more about NSF's internal posture. We used to have a lot of our panels be impersonal or a combination of in-person plus people dialing remotely. Now we've moved them all to virtual platforms. As I've said, they seem to be going extremely well. NSF-sponsored conferences have been encouraged to move online or reschedule to a later date. The NSF staff are 100% telework now, and all non-essential staff travel has been cancelled through the end of, it's been postponed. Next slide, please. And here are just a few additional resources. They're available at this nsf.gov/about/congress/fact sheets. that talks a little bit about what we've done for COVID-19, and also some general information about NSF investments in states. Next slide, please. So looking ahead, we'll continue to address flexibilities that can be immediately implemented in COVID-19 memos. Like NIH, we fully support OMB's consideration of possible extensions to their flexibilities. And we'll continue as a recovery planning task force to collect and consider additional internal and external input about the challenges that confront the research community and ideas for how NSF can best help mitigate those. Thank you very much.
Thank you, Dr. Meacham. Thank you, Michelle, and thank you, Barbara. That was wonderful. We have 6 minutes before 3 o'clock, and we can go a couple of minutes over. I know that might create some conflict for those of you that have 3 o'clock meetings, but if you can stay, we do have lots of questions. So Alex, I'll turn it over to you and we'll start pushing through them.
I can't tell. Can you hear me?
You're on, Alex. Yeah, we can hear you, Alex.
Okay, great. So we do have several questions that are for the full panel. Just confirming, I know both Stephen and Michelle have addressed the COVID funding, that you've been distributing it. I'm not sure, Barbara, if you can speak for all of DoD, but where are you with the COVID funding, and are there going to be more, is there more funding? It sounds like NSF might be running out a little bit, so I'd be interested to hear.
So this is Barbara, and I am not in a position to be able to answer that at this time.
Okay. There's another one regarding supplemental funds, recognizing that most universities have policies that allow them to continue to pay on their awards even if the individuals are not working. Has there been more consideration regarding ensuring that funds will be available for the investigators to complete the research?
So I guess that's a multi-billion-dollar question.
Right.
So NSF's policies governing the request of supplemental funding remain unchanged. However, our capacity to provide supplements while continuing to support new research is really limited by the size of our appropriation. So one of the things that we're asking for help from the research community with is helping us identify roughly what proportion of currently active awards are likely to need supplemental funding, and just what scale of funding are they likely to need. So for example, if we have someone who's on a 3-year award and their university has moved to, has shut down labs for 3 or 4 months, is it roughly 3 or 4 months worth of additional funding, prorated, 3 or 4 months prorated of the annualized award amount? Or is it more, or is it less? We know, for example, that it's going to be very field dependent as well as probably institutional dependent. Projects that are scheduled to use scarce resources or platforms, for example, research that depends on a ship, a 3-month delay might mean that they've lost their opportunity to do field work this summer, to go on a research cruise this summer. And then the way the ships are scheduled, it might be a year or more before they can get another slot on the research cruise. Or it may be that the opportunity has gone by, and so the award is going to have to, the PI is going to have to think about refocusing the research. So without getting a lot more input from the research community, it's hard for us to know exactly how big that demand for supplements is going to be.
Anybody else want to address?
Michelle or Dr. Lauer, would either of you like to talk about supplements? I know, Dr. Lauer, you mentioned Dr. Collins' $10 billion number.
I really have nothing more to add to what Steve said. We're in a very similar situation, and you know, the reality is that we're not in a situation to be able to make grantees whole. The resources just simply aren't there. There may be a few cases where we're able to to supplement specific awards because of compelling situations. We mentioned in our guide, we talked about possible supplements for clinical trials, but all of these will have to be handled on a case-by-case basis, and you know, we're dealing with limited resources.
Jim's on mute. Barbara,
So
I'm sorry.
I guess I'm just going to reiterate what has been said. We sat down as an enterprise and tried to say, can we blanketly make a statement of concerning supplement, continuing our resources, continuing on. And we determined that it just is not capable to do that. It must be done on a case-by-case basis. But do know that the DOD, across DOD, we're trying to work together to come up with some commonality of things. And we're also trying to work with our congressional partners on moving forward and how are we going to address it and setting that up. I think the other thing, if I may throw in, that we've talked about that I tried to allude to, we don't know if when we get funding efforts and as we get moving back in over the next year or so, are the trajectory, is the goals of where we need to do in our research enterprise across the government, is that going to change how we look at, not only look at research, but what we are willing to fund? Will we look more at funding this infectious disease and the different things of how do we protect against some of these versus some of the other science efforts that have been going on?
Thank you. Alex?
another question regarding funds. Have agencies or institutions considered restart fees, especially for clinical type of activities that needed to be shut down and now restarted? These were the costs associated with the duplication of efforts for the start, the close, and then the reopen.
So I'll take that. This is something that we explicitly discussed in a guide notes that we put out back in March on clinical trials. We understand that clinical research, clinical trials will involve certain kinds of unanticipated incurred expenses that will be necessary to preserve investments. Each of these will have to be handled on a case-by-case basis, so you and your investigators need to speak with our staff on the specific circumstances, but as much as we can, we will attempt to address that.
Okay. If the next question for anybody on the panel, this is in somebody asking if an institution decides to stop their pay continuity programs, meaning stop paying employees who are unable to work remotely or in person. They want to know, should this be expanded to the research projects funded by federal agencies as well, under the flexibilities offered by OMB? So I think what they're asking is, does this have to be, if they're looking at employees who are unable to work remotely, would this apply across the entire institution, or can they only do it for federal funded projects?
So Michelle, this is Barb, and mine is if I may take the liberty to say, I think this is a question that we need to take back to discuss with OMB and our research enterprise across the federal agencies to see how that would affect these flexibilities that they've already given us to do. I don't, Michelle, if you have any other insight in that or not.
I think Michelle's on mute.
Can you hear me?
We
Yeah.
can
Now
now,
we can.
thank you.
Yeah, what I was going to say was, I think we have a response to that. I think in the OMB requirements, then that wouldn't necessarily apply to the recipient institution as a whole, reminding folks that these are grant and aid, right? And so the flexibilities would only apply to those research projects. And I think that that was something that was made pretty clear in the administrative flexibilities, that it would apply to research personnel that are participating or impacted by the grant, or at least that is exactly what NIH's FAQ outlined. Applying it across the institution, I'm not sure how we would do that under OMB cost principles. It just wouldn't be applicable, and I'm not sure that we would be able to provide even an audit test for that. So I think the OMB requirements and the guidelines are clear in that space, Barb.
I think
Okay,
the
I guess
nuance in there, Michelle. I think the nuance in there, Michelle, is if you all authorize us to continue to pay non-productive personnel, do we have to continue to pay using institutional funds for everybody else? Right, which is kind of what we're doing now, but if
That's
this
right.
is extended, is that anticipated to be the same requirement, that we would
It
have
would be
to
the
treat
same.
it consistent?
Yes.
Okay, so
it would
Jim-
have to be treated.
Jim, I'm sorry,
Yeah.
I understood the question a little differently. Was
Okay.
that, this is Barb, that if the institution no longer used their funds or non-grant funds to pay for time for people that, were not, working there, and they took that away, could we continue to pay the time for the researchers based on the grant, through the grant award, like we're doing now with the flexibility? And that's the one, in answering the question that way, if you stop paying with non-federal funds, can you continue to pay those people with federal funds? That's the question that I believe we would need to get some clarification on.
So if we're looking at the question that way, I believe what we stated, Jim and others, is that in our guidance, we stated that if there are policies, institutional policies in place that allow for you all to charge those costs, that they can charge those costs to the NIH grant project. And I think we were very clear in that piece. If we're looking at it from that standpoint, that was answered by the NIH FAQ, that we would allow those charges, as long as the institutional policies that were already in place for disasters, emergencies, and those kinds of things, we would allow those charges.
Great, thank you. Good clarification. So we'll have to talk about some of that nuance offline. Alex, anything else in the remaining moment or two?
We do have a few specific questions to NIH that perhaps we could follow up directly with Michelle on, since we'll be archiving these. I think for the full panel, I think NIH has made it quite clear during your presentation, Michelle, in fact, about the need for tracking costs and impact to ramping down. But it might be interesting to hear the level of detail that the other panelists are asking. The communications and documentation that you will need for us tracking our ramping down.
And Alex, to clarify, do you mean the role of progress reports and so forth, and
Correct.
implications on project? Okay. So whether it be a grant or a contract, certainly in DOD's case, but also in NSF for grants, is there clarification as to what should be programmatically communicated from the standpoint of non-productive effort, donated PPE, additional finances needed, programmatic implications, adjusted aims? I mean, the long list of things.
And to whom? So sometimes we hear tell the program officer, other times we hear tell the grant specialist. So that would be helpful as well.
So, so this is Steve. I'm not sure I know exactly the question you're asking, but let me give one interpretation of it. As far as financial tracking, that you would need to follow the standard NSF practices there. Anything funded with the special COVID-19, the CARES Act appropriation is needs to be, the financial system needs to be able to separate what you're spending of the CARES Act awards and what you're spending through NSF's regular appropriation. But that should be easy because we are deliberately not commingling funds on awards. As far as progress is concerned, if a project runs into delays, which obviously a lot of them are going to do, you should still try to submit a progress report on the usual schedule. And obviously you'll probably have less to report. Just describe the circumstances in the usual progress report. That's particularly important for anyone funded with, well, it's important for everyone. In the case of people funded on continuing grants, timely submission of those reports is important for releasing future funds.
Barbara, any quick comment as a final thought?
So the basic comments are, is I believe in our performance one, in the RDR, in the RPPR section, there are places for you to put issues that have arisen and things that have stopped you from making the progress that you're moving forward. And I can't reiterate that any more clearly, is that we need to do that. We need to continue to track your records as you would COVID-19 money, following all the tracking and everything, as Michelle pointed out, that would go in the audit pieces with it. You need to do that for COVID-19 the same way you would do it for your other funding levels too.
Wonderful. Well, thank you. As always, we never know how long we need. I sometimes think we could almost always go longer when we have this many people on such a hot topic. But thanks to Lillian, Denise, and David for the coordination of this. And so much thanks to you as the plenary speakers and the panelists. It was really helpful. And also, Alex, I appreciate you triaging the questions here. So thank you again. We will, any unanswered questions, we'll work with the panelists to get answered and put them on the FDP website. Next slide, please. So Lillian, is this me or is this you? I'll go ahead and do it just in the interest of time.
Yeah.
Okay.
So thank you everyone for joining us. We have a few more meetings for this May virtual meeting coming up. One later this afternoon from 4 to 5 and the other tomorrow from 1 to 2:30. Please join us. But this is all the time we have for this session today. So a big thank you to our speakers. And as a reminder, if we did not get to your question, it will be posted with a response on our website, along with meeting recordings, slides, and a short summary. Thank you all for participating and have a good day.
Thank you.